looking at the current field right now, are there particular candidates or even currently established that fits more in alignment with what we're learning from this?
So there's 4 drugs approved for treatment of sickle cell disease by the Food and Drug Administration. So those drugs being hydroxyurea, which was approved in 1998, I think. And then more recently, we have a drug called L-glutamine, also called Endari, which was approved about 3 years ago. And then there's another one called crizanlizumab, as well as voxelotor, which were both approved in November of 2019. So of the drugs, 4 drugs I mentioned, so hydroxyurea and voxelotor can increase hemoglobin levels. And so it is conceivable that these medications might have some benefit in decreasing the risk of certain complications in patients with sickle cell disease based on the effect of improving hemoglobin levels in these patients.
And what does this do to, I guess, our current understanding when, there's always a consistent trend. And again, sickle cell disease, hardly my expertise in terms of coverage, but we always notice consistent trends in specialties, especially in fields with competitive agents of care. There's always very consistent trends of endpoints and outcomes that we're assessing. Does this kind of buck that trend, or is this something that's aligned with what we're starting to develop our clinical understanding of what we need to look at next with these agents?
So I think, so that's actually a very good question. So I think in the field of sickle cell disease, I think historically, the clinical endpoint that most drug therapies have looked at has been painful crisis. So that's the most common complication that sickle cell patients would experience that cause them to come to the hospital to see a doctor or go to the emergency department. And so historically, most trials that looked at complications in sickle cell disease look at painful crisis as the clinical endpoint. But more and more people are beginning to think about looking at other complications because sickle cell disease is a multi-systemic type disorder. So patients can have pain, yes, and it's the most common complication, but patients can have involvement of pretty much every organ system, And so, so we realize that for us to adequately treat patients with sickle cell disease, we have to think beyond pain. And so people are beginning to think about looking at other complications in these patients as well.
That's really interesting. The emphasis initially being quality of life. That's fantastic to hear that the field at least has emphasized that as a priority initially. It's so frequent that we look for, these sort of metric-based outcomes in hopes of it better informing. And then after the fact, kind of look to be like, what's the tolerability? What's the patient satisfaction and quality of life improvement? So I feel like it's pretty good to have that assured from these agents when now we're looking at a much stronger biomarker for inherent risk with it, right?
Well, yeah. So I would add that the initial studies that have looked at painful crisis haven't looked at quality of life per se. So some studies have looked at quality of life, and there is evidence that hydroxyurea can improve quality of life in patients with sickle cell disease. But we actually looked at pain episodes. So patients actually have physical pain, right? And so we assessed the effect of this medication on physical pain. But the way we assessed pain was kind of interesting because we didn't ask patients to define how severe the pain was per se. And so the kinds of surrogates, the way we defined pain was based on healthcare encounters. So did you have pain that was bad enough that required you to go see a doctor? Did you have to go to the emergency department, or did you get admitted to the hospital? So patients typically would have pain and they treat the pain at home with pain medicines, things like from like Tylenol or much stronger pain medicines. But if the pain is controlled at home, then they end up going to see their doctors, either going to the emergency department. And so most of the studies we have done looking at pain have looked at healthcare encounters. How many times you go to the emergency department in a year or a month or things like that.
Right. All right. Excellent. Thank you for that, Doug. I appreciate that. And looking forward a little bit, I mean, you alluded to, of course, how this sort of informs, the assessment of agents and how exactly they're providing care for patients. What else do you see this? I mean, this is a huge understanding of, a disease that already doesn't need comorbidities to be a pressing concern for a treating clinician. How else does this, I guess, inform and improve upon the next round of clinical assessment, and where does it go?
Are you talking about the study we did, or just kind of like?
Yes, the meta-analysis.
Yeah. So I think it kind of adds to our understanding of disease pathophysiology. So I think more and more based on studies in animal models and based on clinical studies, epidemiologic type studies, we are understanding even more the role of anemia in patients with sickle cell disease. But this does add an additional piece to that and tells us that anemia is important in these patients, and it's not something we should just kind of like ignore, because perhaps if we improve the anemias that these patients have, perhaps might not only improve their quality of life, but it could also decrease the risk of certain complications. So having said that, we have to do these studies because these are just kind of observational. These are models, right? And so we have to do the studies and actually prove that if we treat patients and we have them have their hemoglobin levels increase, that we can actually see clinical benefit in that setting.